to our next speaker. It's Dr. Tessa Moll. Dr. Tessa Moll is a medical anthropologist and postdoctoral research fellow at the School of Public Health at the University of Witwatersrand. Her research interest concerns the social and cultural aspects of assisted conception technology, post-genomics, and health policy in South Africa. She is currently involved in a project on cross-border reproductive travel in sub-Saharan Africa and working on a book on fertility care in South Africa.
And thank you for joining me today, and thank you for the organizers for inviting me to present my research. My name is Dr. Tessa Moll, and I'm a medical anthropologist specializing in assisted reproductive technologies in South Africa. So first, what on earth is a medical anthropologist? I get this question a lot, in fact. So anthropology as a discipline is often traced back to the work of Malinowski, who traveled to remote islands near New Guinea in the Western Pacific, and he wrote about culture, social structures, and family life of the islanders. So these days, we understand that culture is not just found in remote islands, but part of our lives in cities, in our contemporary workspaces, and in high-tech medicine. Medical anthropology in particular studies health and well-being and how culture influences experiences of illness and the practice of medicine, processes of healing for the individual, and as IVF and assisted reproduction involves cultural ideas about what is a family, what makes kin, the relationship of science and society, and ideas around gender, this is of course an interest in anthropology. So in this talk, I'm going to be presenting the research that I did, which focused on providing a social and cultural account of IVF in South Africa. Fertility treatment is, of course, a high-stakes medical encounter, and many patients and providers in this room know this very well. My first question concerns providers and how they communicate the uncertainty inherent in the IVF process. The second question is how patients manage that uncertainty. I finally present information related to a current project that I'm working on that is on reproductive travel in Southern Africa. So the study I'm presenting here comes from my doctoral research in social anthropology at UCT. Doing anthropological research is a really long-term endeavor. It involves being embedded in locations and doing interviews. In this case, I observed at 3 fertility clinics over a period of 14 months. I interviewed more than 40 patients, 12 egg donors, and over 20 doctors, nurses, embryologists, egg donor agency professionals, and psychologists. And this research is, of course, only possible with the generous participation of those people that I worked with, many of whom took time in their busy lives to share their stories with me. And I'm very, very appreciative of all that time. So my objective in this research was to understand 2 things. And the first was cultural norms that were shaping IVF usage. The second was about uncertainty and understand how doctors communicated uncertainty about the IVF process and how patients understood and managed that sense of uncertainty, where they ultimately placed successes and failures. So firstly, what am I meaning by uncertainty? This is a state that is characteristic of many medical encounters. Simply, there's no fixed or known outcome. The future is ambiguous, and there are no guarantees. It creates feelings of both hope and anxiety, and often both at the same time. It often creates situations where patients must seek out and rely on expert knowledge. Uncertainty compels us to ask questions. What do we know? How should we act? And what futures will we imagine and been brought into the present if we act in a certain way? Why is uncertainty such a dominant feature of the IVF process? And for one, there's high stakes for patients. Becoming a parent has significant individual, cultural, and social importance. Having children may facilitate couples being viewed as socially legitimate families. Having children can also provide a desired sibling for already existing children. For some, pursuing a desired child is also stalling the end of one's reproductive years, acknowledging and accepting and grieving that end. At the same time, there are incredibly high costs for those involved in IVF and those pursuing conception through ARTs. This is, of course, for one, the obvious financial cost. I'm also involved in a recent survey that is looking at the debt burden that South Africans are involved in order to finance their fertility treatment. Many have to borrow money from their own parents, use savings that were put away for other future costs, or they delay significant purchases, such as buying a home. But there's also clear emotional costs. Psychological studies have demonstrated a high burden to the couple's relationship, as we saw in that film just now. In my interviews, I also found burdens to other social relationships. IVF patients avoiding family members, friends, and community members to conceal or avoid speaking about their infertility and the IVF process. There are also emotional costs in mourning losses that occur through the process. Many experience IVF failure, but also miscarriage. There's also the emotional costs of feeling shame and personal failure for the failure to conceive naturally. These costs are also social costs. They may disrupt an individual moving on to life stages, such as parenthood. Finally, these cost uncertainties are compounded as IVF must often be repeated several times before a live birth. And these uncertainties are increased as trajectories are numerous. Yesterday, we heard Dr. Clark speaking about all the add-ons that can be added to treatment. And this increases the options, but also increases the uncertainty, because it adds more questions about how to proceed, what to try, when to continue, and when to stop. So in this context, I'm asking two questions. And the first is, how do doctors and other medical providers communicate patient prognosis and uncertainties? During my observations of numerous doctor-patient consultations, I found that doctors are often trying to navigate what they think of as, or excuse me, what I think of as a triangle for trajectories. And this triangle is kind of like a three-footed stool. The medical provider is trying to keep in balance so that the patient remains in treatment, particularly as IVF is often a long haul. First is a medical prognosis with variables such as the intended mother's age, the cause of infertility, and the contributing health factors that affect subfertility, such as smoking or being overweight. But providers are also trying to ascertain the social capacities for treatment. What treatment options is the patient willing to consider? Will they only use inseminations, or will they consider IVF or ICSI? Will they consider donor eggs? Will they consider surrogacy? Some of these questions relate to the provider's understanding of the patient's moral framework, which is often their religious background. Providers are also trying to understand what are the financial resources the patients have towards treatment. Can they have an extra cycle to try something new, or are they limited to only 2 cycles? Providers also try and ascertain social support and the couple's motivation. Are both partners fully on board for a given treatment option? Do they have community or family support behind them, which can offer support in terms of finances, but also emotional support and help with things like watching over already existing children in order to come to appointments? Finally, the third leg of the stool is that providers try to acclimate patient expectations, and they do so through the use of treatment statistics. That is, they make sure to show patients the statistics, the graphs, the charts, so that the patient's hopes are acclimated appropriately. Here are some quotes from my interviews with doctors. Many doctors I observed believe that managing patient expectations, making sure that they did not hope too much, was important to ensure that disappointments did not lead to ending their treatment prematurely. For them, good care was tied up with managing hopes and uncertainties. And thus, doctors again and again reiterated with me that they provided patients with the statistics of treatment outcomes, which at times are very low, to prepare them ahead of moving forward with IVF. However, in my observations, I couldn't help but notice that there were several tensions when looking at things from the patient perspective. Many patients are being shown sometimes these low chances of success, at the same time as they sit in offices with images of babies, which reflect these ultimate hoped-for successes. One nursing sister I met with said it best. I was explaining to her my interest in treatment statistics and understanding how patients manage treatment when hearing that a procedure may only have a 10% chance of working. And she looked at me and she said, "Well, Tessa, why else are they here? They're not here for a cup of tea, or else that's one very expensive cup of tea. Patients must hope for the best, otherwise why else would they be in the clinic?" For patients, there also existed a tension when looking at any statistic of medical prognosis. These are aggregate numbers. Any statistical rendering does not actually tell that individual about their future, about their own treatment. And these tensions can be summed up by this quote from a patient I observed during a consultation. She asked an embryologist, "How can I hope for the best while still expecting the worst?" And for patients, this question gets to the heart of an enduring uncertainty in fertility treatment, that in order for them to continue with treatment, they do have to hope that it'll work. This gets to our second question. How do patients manage uncertainty? Or rather, where do they imagine responsibility for successes and failures lay? For comparison, there's been many anthropological studies of IVF treatment in other parts of the world. In the UK, for instance, patients reported they had ultimate faith in medicine and fertility technologies. That is, IVF could offer this technological helping hand where nature had failed. In the US, many women reported feeling personal responsibility for their failures. They tried fastidiously to avoid any mistakes, follow advice strictly, timing their shots, eating perfectly right, keeping their stresses low, but they often attributed failures to themselves. In strongly Catholic Ecuador, patients brought God into the lab. They believed that medicine could take them some of the way, and the rest was up to God. In South Africa, I observed a highly plural response. That is, patients had many, many places where they placed responsibility. Faith in God, for one, was present among many patients, 14 of the 41 I interviewed. Here are several quotes that are indicative of patients' belief in God, or prayer as a place to reassure themselves. Many reported, similarly to those in Ecuador, that they had to leave some of their certainty with their faith and pray for the best. For them, medicine may take them some of the way, but ultimately their successes depended as much on God as it did on the newest technique. Like those in the UK, many had faith in medicine. For instance, in the first quote, this patient I met here said he felt he could attack the problem of infertility in a systematic, scientific way. Medicine will eventually work. They felt they should have a strong, evidence-based approach. Others also acknowledged, however, that medicine wasn't perfect. Here in a discussion with patients Abigail and Oliver, they're weighing what to do with their embryo transfer. They had a good embryo, but a poor uterine lining. Should they freeze and wait and use the second best embryo now and wait for a better uterine lining? But would they ever get a better uterine lining? In mulling these options, it was clear that there's many evidence-based practices, but they don't incorporate the wide social factors that shape patient decisions. Abigail and Oliver were talking about taking time off work, how to travel to the clinic, freezing costs, and whether her lining would ever actually improve. In the end, they had to conclude that there were simply no guarantees. Thus, with no guarantees, luck was also a factor. Luck was an excess beyond other factors that did not have a role to play. It was beyond medicine, God, or their own role, and sometimes things were just the roll of a dice. Many, many patients I spoke about rolling the dice, going to the casino. Jane, in this example, thought she was already pushing her luck because she had twins. Many believed that there was simply nothing to do but keep on trying and their luck might change. Or as with Oliver here, that they had already had good luck. Let's not risk it further and blow these chances. Luck accounted for what medicine or God could not. And in a context where they feel uncertain, many tried to do what they could to optimize their chances for success. This led to women that I interviewed, like those in the US, and particularly women, to not only talk about responsibility for IVF successes or failure, but take the blame. Men felt very anxious too about their role. Many said that they felt that their role was limited, so they had to do everything that they could do to ensure it was done correctly. But often the feeling of personal failure for a lack of conception fell on women. Women I interviewed tried their best to optimize their health, losing weight, eating supplements, having a good diet. Others quit their jobs to reduce stress, or as to focus all their energies on IVF. After IVF failures, many mulled over the reasons and what they could have done to contribute to it. And finally, what was a unique feature in South Africa was the attribution of responsibility to the embryos. Because of the growing appreciation of embryo genetics and the role it has to play in the failure or success of IVF, and the growing use of PGTA, many patients attributed the ultimate responsibility to the embryos themselves. They, the embryos, will simply take or they won't, and there was nothing that one could do. This had the effect of relieving other areas of responsibility. Instead of blaming themselves or blaming medicine, the patients understood that ultimately embryo genetics were responsible for IVF outcomes. So in conclusion, uncertainty and having to navigate anxieties, hopes, and fears is an enduring feature of the IVF journey. Providers often try to lean on just the facts to acclimate patient hopes, but for patients, these numbers are much less straightforward. Patients, in turn, have a plurality of responses to the uncertainty. Some lean on God, others lean on genetics. This plurality is reflective of the diverse society of South Africa itself. And as I said in the beginning of this project, or of this presentation, is that this is only possible through the generous participation of patients, doctors, clinics, and medical staff. And I've been very grateful for their help. I'm also part of a current research project that is looking for participation. This is a research team at Wits University and Monash University in Australia and with the University of Amsterdam. And we're exploring those who are traveling for assisted reproductive technologies. Our research has ethical approval both from Monash and Wits. We are speaking with everyone from patients who are traveling to or from South Africa, medical providers that are traveling within the region to provide fertility care, and reproductive assisters, by which we mean egg donors, surrogates, donor agencies, or those who facilitate IVF travel and travel overseas. Our aim is to understand this regional travel for assisted reproduction and to understand the experiences of those traveling. So if anyone is interested, you please feel free to reach out to me. And thank you very much to the Fertility Show and inviting me to present. Thank you all for listening, and I'm happy to answer any questions if anyone has.